Thanks so much for joining us today, Dr. Wallace.
Thank you.
We will just dive right in. All right, take it away, Dr. Wallace.
Good evening. I'm Dan Wallace. I'm a rheumatologist. I'm based at Cedars-Sinai Medical Center, and I was asked to review some of the laboratory testing that is done for lupus. I will talk for about 15 minutes and then answer a group of questions that I have not seen but have been pre-submitted. So ANA is more than a Japanese airline. It stands for anti-nuclear antibody. And what is an ANA? So there is something in biology called a cell line, where cells are grown in tissue culture. And there is a specific type of cell line called a HEP2. And HEP2 is a cell line that was chosen because the nucleus, every cell has a nucleus and a cytoplasm. The nucleus is very large, so we can see all sorts of parts of the nuclear material. So what happens then is you have tissue culture with a group of cells, and then lupus patient serum or blood is added. And then if there are antibodies to the cell nucleus, they are identified by a tag, which is an immunofluorescent or a colored material detected on a fluorescent microscope. And that is what an ANA test looks like. Next slide. So what we're seeing here is cells in a tissue culture dish that these stains, or what you see is the green background, is the cellular material, and the material that is on top of the green is what the nucleus is. And if the nucleus stains with an antibody, it could have several patterns. It can have a homogeneous pattern, which is where it's all over the place, a peripheral pattern where it's just the rims, a speckled pattern that looks like a speckled donut, or a nucleolar pattern where a certain part of the nucleus, called the nucleolus, stains. Most people with severe or significant lupus have a homogeneous pattern. If those with anti-DNA, double-stranded DNA, have a peripheral pattern. Those who have mild disease or other lupus-related diseases have a speckled pattern, but and a certain number of normal people can have a speckled pattern. It's what we would call background noise. And for the nucleolar antibodies, this is an antibody to RNA or scleroderma or Raynaud's, where the nucleolus rather than the nucleus within it is lit up. Next slide. So what we do is we dilute the blood, and every time we dilute it, it's a new titer. So as you can see at the bottom, there's 1 to 40. We dilute it once, it becomes 1 to 80, 1 to 160, and you double the number each time. The higher the number, the higher the titer, the more indicative it is of a real autoimmune condition, as opposed to the fact that up to 13% of the United States can have an ANA without any autoimmune disease. Next slide. So anti-nuclear antibodies are very sensitive for lupus because it's very hard to have lupus if you don't have an ANA. If you have a negative ANA, a diagnosis of lupus is unlikely. However, there are certain conditions where if you've given a patient prednisone for many, many, many years, or you've given them strong chemotherapy, eventually an ANA can be made to become negative, but this is unusual. Next slide. It is not a very specific marker. It's not 2% of healthy people that have an ANA. It's up to 15 to 20%, more like 13%. Rheumatoid arthritis patients and other autoimmune patients can have an ANA. Certain infections are associated with transient ANAs. If you have hepatitis or HIV, an ANA or mono or tuberculosis, an ANA can become negative, can become positive, but eventually if the disease is treated adequately, it becomes negative. There are many medications that are associated with causing an ANA, such as doxycycline, which is a form of tetracycline. So a positive ANA does not confirm the diagnosis. It has to be, it's part of the context of what we would look for. Next slide. So there are other antibodies that are part of criteria for lupus that are specific. There's antibodies to double-stranded DNA, which is seen in a little more than half with lupus. There's antibodies to SM, which is a lady named Smith, who it was named after, which is positive in 25% of lupus. But there are other very specific antibodies in the blood of lupus patients. Sometimes the levels of these antibodies are useful. For example, antibodies to double-stranded DNA fluctuate with disease activity and are found, let's say, with lupus nephritis, are very good for monitoring disease activity. Next slide. So antibodies can also bind to the cell membrane or the blood vessel walls. And the most important one are anti-phospholipid antibodies, which are associated with clotting proteins in the blood. And the anti-phospholipid antibodies are seen in a third of all patients with lupus, and 1/3 of them have a clot as a result. Clots can occur in arteries or veins. In arteries, they cause a stroke. In veins, they can cause a phlebitis. In pregnant women in the placenta, they can cause a miscarriage. Next slide. So this all stems from the very first test that was historically used to diagnose lupus, and that was the LE cell that was discovered by Malcolm Hargraves at the Mayo Clinic in 1948, and it was superseded by ANA, which came out in 1957. But this is a picture of an LE cell, and basically this was the first blood test for lupus. Until then, the only way we could diagnose lupus was by doing a biopsy and looking at tissue. Next slide. So these are the 1/3, 1/3, 1/3 rule that I mentioned for phospholipid antibodies. Phospholipids are on cell membranes, and we can have cardiolipin antibody, which is a phospholipid antibody. We can have reagin, which are those with lupus who have a false positive syphilis serology, or we have the lupus anticoagulant, which is another test. Next slide. So for those who have anti-phospholipid or cardiolipin antibodies, there's lots of clinical associations. For example, in obstetrics, there's recurrent miscarriages. In hematology, there's all sorts of strokes, low platelets, anemia. In neurology, we could have clots or strokes, transient ischemic attacks, epileptic seizures from that, or migraine. In cardiology, you can get phospholipid antibodies on the valve of the heart, which causes inflammation or clots and raises blood pressures. In the lung, we can have clots to the lung or raise pressures in the lung. In the skin, we can have gangrene, ulcers, or a sort of a Raynaud's livedo reticularis, which is a lace-like checkerboard panel in the skin. And there's many drugs and many infections which are also associated transiently with these antibodies as well as malignancies. So it is not necessarily specific. Next slide. So this summarizes what I've said. Again, for those who came in late, HEP2 cells is a cell line, a human epithelial cell tumor line. We add lupus blood. And if the antibodies are present in the blood, they are tagged with the materials, and they can be different patterns, such as homogeneous, speckled, nucleolar, or centromere. Next slide. And finally, no, this is not finally. And then there are many other important autoantibodies in lupus. You can add antibodies to the cell nucleus, which is ANA, or anti-nuclear antibody. Anti-DNA, which I mentioned, also is to the nucleus, but there's a whole host of other antibodies like histone, SM, and RNP, which target the nucleus. We can target the cell membrane, which is anti-phospholipid antibody, which I've mentioned. We can target the cytoplasm, which is anti-SSA, SSB, ribosomal P. We can target red cells, white cells, platelets, nerve cells, or immune complexes. So there's about 150 different antibodies that are associated in lupus. The most important ones are what is shown here. Next slide. So there's no single test that determines whether a person has lupus. We use a variety of tests which help the diagnosis, make the diagnosis. So if one has an ANA, we do a reflex panel where we look for some of the other antibodies, such as DNA, SM, RNP, SSA, SSB. We look at cardiolipin or phospholipid antibodies. And sometimes we have to do a biopsy to make a diagnosis, such as a skin biopsy or a kidney biopsy. Next slide. So for monitoring disease progression, we have many different tests that we can do that are, the simple one is a CBC, which looks at your hemoglobin, your white count, your platelets, and it's low in lupus. Generally, urinalysis, we look for protein, blood chemistries, we look for liver function, kidney function, and protein levels. For inflammation levels, we can look at sedimentation rate. For also inflammation, we can see if complement, which is a protein that's elevated in lupus or decreased in lupus, gets consumed. We can also do X-rays and imaging tests of affected organs to look for inflammatory products. We've already discussed the anti-nuclear antibody patterns. That diffuse is mostly lupus. Peripheral is anti-DNA. Speckled could be normal or other rheumatic diseases. Nucleolar is the nucleolus or the nucleus within the nucleus, which is seen in scleroderma. Antibodies with lupus are seen in just about everybody with lupus, but it's not specific. You have to rule out infection, cancer, and healthy controls. So therefore, we look for anti-double-stranded DNA, which is highly specific for lupus, and it's a very good way of monitoring kidney disease. We look for SM, which is also very specific for lupus. Next slide. So over about 2% or almost 22 to 20% of healthy people have a positive ANA. It can be seen in rheumatoid infections, and it does not confirm the diagnosis. Next slide. The diagnostic accuracy of lupus antibodies depends on the disease. So if you have Sjogren's, you have a 48% chance of having lupus. You have Raynaud's, you have a 64% chance of having lupus. You have rheumatoid. I don't mean lupus, ANA. Rheumatoid, you have a 41% chance of getting an ANA. Although these are seen in healthy people, these are fudge factors which allow a rheumatologist to be the consummate clinician and look at all these levels and then say, this is what you have and this is what it means. Next slide. So I think we've already covered this. That's a duplicate. So I think I've covered my 15 minutes. So Bree, surprise me, dazzle me, challenge me, and see if I can answer your questions that the people on this call have already submitted.
Great. Thanks, Dr. Wallace. We have several. Why does my lupus lab work not always line up with how I feel physically. Is that something you see commonly?
Yes, there's something called a lupus type 1 and lupus type 2. Type 1 is when you have where the antibody levels directly correlate with the symptoms. Type 2 is when you're tired and achy, and the blood tests, you have mental fog, and the tests don't necessarily correlate. So these laboratory tests are only good for type 1 lupus. They're not good for type 2 manifestations of lupus, and we need better tests, and there are some that are in development.
Interesting. What are the factors that you've seen with patients that help put someone into remission?
Remission is, lupus is an inflammatory disease. So when we give somebody an anti-inflammatory drug, we can put them in remission, but remission is a loaded word. There's laboratory remission, which means your blood tests improve. There's clinical remission, which means I feel well. There's disease remission, which means everything gets better. Remission means you still have lupus, but you're not, you don't have symptoms.
For sure. Are there lab tests that must be positive for a lupus diagnosis?
The 2019 American College of Rheumatology criteria for lupus mandates an ANA of at least 1 to 80. Some of the older criteria for lupus do not require it, but the only blood test in any criteria that has that is an ANA. But as I mentioned, there are some people who used to have an ANA, but it became negative. So the criteria have been revised to say you could have a historical ANA and still have lupus.
Got it. Is it recommended to do labs after a flare, or is it better to do regularly scheduled labs?
All of the above. The only way to tell if you're in a flare is to do a blood test. You can sometimes see a person who's clinically flaring, but without the blood tests being done, you cannot tell if there's a flare.
Got it. Does having a persistently high anti-SSARO tell you anything about lupus severity or disease activity?
SS stands for Sjogren's syndrome, or it's a Rho antibody, R sub O, and it is seen in 70% of people with Sjogren's, which is dry eyes, dry mouth, and arthritis. It's seen in 30% of people with lupus. It's seen in 1 in 1,000 healthy people. So the level or the amount of SSA does not make any difference. It's a yes or no.
Okay, thank you. How do you monitor your patient's SLE disease activity if it does not always correlate with C3 and anti-dsDNA lab results?
We look at something called acute phase reactants, which are sedimentation rates or CRPs. We look at the CBC. We look for anemia, low white count, thrombocytopenia, or low platelets. We look for high proteins. We look for liver injury. We look for kidney injury. We look for protein in the urine. We look at albumin levels. So all of these are very important.
Wow. Are there any lab values that you use as for a predictor for prognosis long-term?
It depends, there's 9 organ domains in lupus. There's heart, lung, kidney, liver, brain, bone marrow, and so forth. And some people only have one domain or one area of involvement. So there is no one test that spans all the organs there or domains. There are specific tests for specific domains.
Got it. Okay. And then last question, why would a rheumatologist order protein electrophoresis in a lupus patient?
A serum protein electrophoresis takes all the proteins in the body and parses them into components such as protein, albumin, and it also includes the globulin levels, the gamma globulin levels, gamma globulin G, A, M, D, and E. And from looking at this, you can diagnose a lymphoma, you can diagnose inflammation, you can diagnose allergies, and look for susceptibility to infections and a host of others.
Wow. Thanks, Dr. Wallace.
Thank you. Anybody from the audience want to ask a question? We have a few minutes.
think we have one more here. Do you consider Benlysta a safe drug?
Benlysta is a very, very safe drug. It improves lupus 70 to 80% of cases. It is in the controlled trials, the percentage of people who discontinued Benlysta due to a side effect was only 3%.
Okay. And then let me just see here. Last question. Let's see. Since I've had lupus, I've developed immune deficiency. Does this ever correlate with lupus?
Immune deficiency means susceptibility to infections or complications of the disease from not being able to fight it. So yes, it does correlate with that.
Great. Well, thank you so much, Dr. Wallace. We really appreciate your time.
You have a great evening, everybody. Bye.